We have actually we have a couple of live chat, or at least one live chat question. So perhaps we could take that first before I open to the floor. Sonia.
Okay, this is a question from somebody called Toot on live chat. What do you think about the Stanford research and the white-grey matter differences?
I don't know the Stanford research, the details of it, but this is another tool by which one can study the living brain, and using MRI it is possible to make measurements of different compartments of the central nervous system. So the grey matter is of course where the cell bodies of the nerve cells live. The white matter is the fiber tracts between different regions. And in humans, in the human cortex, about 45% or so of your cortex is made up of these big fiber tracts. I don't know the study in detail that the caller is referring to, but it is of great interest that some of the first changes in the aging brain are in the white matter, are changes, rather non-specific changes in white matter, and these are associated with changes in cognition. So changes in white matter, changes in grey matter are of interest. They point to the direction to areas of biology that we could study.
Thank you, Hugh. We'll take some questions from the floor now. What I would ask, there are a few. Neil is lurking in the corner there with a microphone. If you could give him time to get to you and say who you are and your question, that would be great. There's a question there then. Thank you.
Yes, thank you for that. Is the microphone working?
Yes.
It is indeed, yeah. Carl Crusko, associated with the Remember support group. About 20 years ago, when I was an undergraduate at Sussex University, now Professor Andrew Smith of experimental psychology, we were looking at the possibility of interleukins and cytokines being associated with some of the behaviours that you're talking there about in people with chronic fatigue syndrome. We were comparing cognitive failures in individuals who were known to have HIV, known to have mononucleosis, known to have shingles and so on, where we knew there was a persistent viral challenge ongoing. And what we found there, of course, is that they all were presenting with the same sort of cognitive failures that you've been presenting to us this morning. There's one question, however, that we were quite unsure of, and I think we still are. At least I certainly still am. And it's this. If we're looking here at an immunological challenge, why is it that we see presenting remitting behaviour in these patients? If that challenge is there all the time, why do symptoms come and go over hours, perhaps over days, maybe indeed over months and years?
So this is a very interesting question in the context of many diseases that involve the immune system. So many of you will know, or even have colleagues or friends with diseases such as arthritis, multiple sclerosis and so forth. And many of these diseases, it's not a constant state. They show this relapsing, remitting condition. And the biology that underpins that is poorly understood. So one idea is that something as complicated as the immune system, there is an inherent instability. So when it's activated, the pathways that must turn it down have to get switched on, but they're not always switched on at the same time, the same rate, and so forth. So this may cause some of the instability. In multiple sclerosis, a disease that I've been involved in the study of, it's pretty clear that about a third, at least, of all relapses are driven by low-grade viral infections. And the relationship between the infection and the relapse is not always clear in time, because the cytokine levels, as you point out, come at different times in different individuals, and that can lead to then activation of the immune system and driving it. Surprisingly, one of the things we don't know much about is what happens to people's cytokine levels over days and weeks. And there are very few studies in normal healthy people or in people with diseases, immune diseases, over time. Many of these studies are cross-sectional studies where people take a blood sample at one day of the week in a large number of people and then look at what happens. They don't measure it again and again and again. And so we don't really know whether people's cytokines are waxing and waning in response to stress, low-grade infections, and so forth, many of which might not give rise to symptoms that you would overtly call, oh, I've got a bad cold. They might be much more subtle than that. So I think that's certainly part of the question, part of the answer.
Very interesting talk and a very interesting answer as well. Thank you very much.
Thank you. There's some questions down the front, Neil, here.
I don't want to be contentious, but we're told in the press that exercise is going to cure everything. It's going to stop us aging, it will cure a lot of conditions. How could the chemicals produced by exercise mediate in the pathology that you've explained?
Fantastic question and very important question. So one of the interesting things, as you pointed out, is there is a lot of interest in why is it that exercise may be good, not just for the heart, but for the brain, people with dementia, and so on. And one of the interesting things that happens when you exercise is muscle makes a whole lot of molecules that are called the myokines, and myo meaning muscle, so molecules derived from muscle. And some of these molecules are anti-inflammatory, so they suppress inflammation. So that's one thing that's very interesting. Second thing is there's some evidence that muscle cells can make a brain-derived growth, BDNF, brain-derived neurotrophic factor, a trophic factor that's good for neurons. And a third molecule that may be involved is another growth factor called insulin-like growth factor. So doing exercise is not only good because it keeps your cardiovascular system in good shape, which is hugely important for every organ, but in particular the brain, but it also makes these anti-inflammatory molecules and molecules that are good for neurons. So it's a very interesting, very important question. And what is interesting is that you don't have to be an Olympic athlete to be in the category of people doing exercise. This very sedentary lifestyle that some young people and others have adopted is a real concern, because it's not exercise, it's physical activity appears to be beneficial for many different conditions, and there's growing evidence that this is around these myokines and other molecules.
Sorry, I forgot to say who I was. I'm Janice Kent, I'm director of the charity, remember.
Janice.
Thank you. Could you just pass the microphone to your right there? Thank you.
Hello there. Is that okay? Thank you.
Sorry, can I just say, can you speak into the microphone quite clearly, because people watching live stream can't hear the
Thank you.
question.
I'm nervous. I'll try and do this
Okay.
well. Firstly, thank you so much for a wonderful talk. That was pitched brilliantly and really great. Thank you so much. I want to ask you about sickness behaviour, and I don't know if this is going to be your right area. There's a group of people with ME, and I'm one of those, who have stopped having fevers. And I was wondering whether you had any idea why that's happening. So if I have a infection, and this is one that there's a test for and it's shown, such as a sinus infection or one of the bad bugs that you spoke about, I no longer produce a fever and my temperature doesn't go up. And it's one of the reasons why my GP has found it so difficult to understand, and why it's so hard for me to get the testing I need if I do have an infection. Any idea what would be happening with that group?
So this is a great question, and the reason why it's a great question is it really highlights why it's hugely important for biomedical scientists like myself to talk to patient groups. Because I heard about this actually at the collaborative meeting. I met some people, and sitting in the group were a couple of patients who had the condition, and a couple of people who've been involved in the care of people with CFSOB. And everybody said, yeah, it's really weird. One of the things that happens to people with this condition is they don't seem to get colds and the associate responses, sickness behaviours, and one of the reasons you know they're getting better is they seem to start getting colds. And I can see people nodding around the room. Now that seems to me, if we don't know the answer to that, it's telling us there's something to dig around in. Because there must be some dysregulation of some networks that we should be able to find out what's going on. So I think it's a great question, and I think it should be right on the list of it would be really interesting to investigate this and see if we can pick apart what it is that's different. Is it that your immune system is now so effective it kills off the pathogen before it ever gets going? Could it be that actually the pathogen is there, but it doesn't evoke the responses that one would typically associate? Could it be that actually you make the appropriate peripheral response, but now the signals don't get to the brain? And I could go on, but you can see there are layers of questions where one could really learn something important about the disease. It's really interesting.
Yeah, that's a slightly different group, because I've got sort of the worst of both worlds in that I do get the colds and I do get the constant infections, but I don't get a fever.
So we'll have to... So
I'm in a slightly different boat.
So even better. So we're going to stratify you into different subgroups of people.
Yes.
And see if we can dig apart what are the differences between you. I think it's a great question.
Right,
very interesting, very
now,
profound.
we're slightly overrunning, but I don't think we can let go of this man just yet, because this is quite interesting. I've got a live chat question and then a question over there, Neil. But take the live chat question first from someone.
Okay, Hugh, this is from the live chat. Why doesn't exercise help people with severe ME?
Why doesn't it? Well, first of all, you should be clear, I'm not a clinician. I don't, it is not my responsibility to look after people with disease. So whatever I said would be presumptuous, because I haven't dealt closely with people with the disease. I don't know, I think is the answer, and I doubt that anyone knows the answer right now. Certainly, as we just discussed a little while ago, a certain amount of exercise is a good thing. But whether that is true for everybody is another thing. I'm not in a position to give an answer to, actually. But again, it could open the box to different types of studies where one could investigate whether exercise in different groups gives rise to the same biological responses that we see in normal, healthy people. So I think there would be interesting things to explore.
A fair response. A question there.
Thank you, Hugh. That was a fantastically pitched talk, really useful for me as an ignorant scientist, but a clinician. If what you're saying is right, the activation of the microglia is the key predisposing factor. That's pretty well established. We therefore ought to be able to go back into the histories of people with chronic fatigue and look for repeated infections as a predisposing factor, lack of exercise as a predisposing factor. So that should be something we should be able to investigate fairly simply. Are you aware of any other predisposing factors that the basic science would lead us into that we should be investigating as clinicians in perhaps large cohort studies?
So certainly the idea of using large cohorts, I think, is hugely important. I think getting a handle on what might be the predisposing factors. I think for sure there's going to be a genetic component. So that would be something that you might ask, that whether if you had enough patients that you could get DNA from, whether you would look for pathways in the, if you like, immunological pathways. The other factor that gives rise to the generation of central cytokines is stress. There's quite a good literature that stress can generate cytokines in the brain, and there's some evidence in animal studies that you can have, if you like, additive interactions between stress and systemic inflammation. So that would be another thing. And if I think of more, George, I'll send you a list.
So I'm going to take 3 more questions, so I've already got stacked up, I'm afraid, but we're running out of time here. The gentleman here.
Thank you. Do you have a view on the use of low-dose steroids, such as hydrocortisone, to address inflammation problems?
As I said earlier, I'm not a clinician, so I'm not close enough to it, really. It would be inappropriate for me to comment, actually. Yeah, I can't help you. I don't give enough people... I've done it to rodents, and I can tell you a lot about what happens to a rodent, but I'd be reluctant to tell you what happens to a person.
I can see I'm going to struggle to restrict this to the last 3 questions I said. Anyway, gentleman at the back there, who I'd already nodded
It's the same Pavin here. I'm a carer for my sister who's been suffering from CFS for the last 37 years. So she was one of the first to be actually identified as carrying ME. Her story is actually consistent with what you said, in that she suffered from prolonged glandular fever, and that would probably have predisposed her, as you've suggested. My question really is, what are the longer-term prognosis? I mean, I'm not familiar with this field, but is there any possibility of unpriming, deactivating this microglia to get people back to normal state? Is it something that's reversible?
Of course, the honest answer is we don't know. This really has only emerged as an idea recently, and of course, what we would like to know now is, can we find ways in? First, what are the molecules that prime the microglia? You know, what are those molecules that bathe the microglia in the brain that lead them to get into this primed state? And we have some ideas, and we're beginning to explore in models whether we can stop them getting into primed state, whether we can stop them increasing their numbers, and so on. So there's a lot of interest in whether that's possible. And of course, I think that's why it's important that people with this disease keep a weather eye, as the expression goes, on other diseases which have some similar characteristics. Because of course, if there are roots in Alzheimer's disease or Parkinson's disease or some of the psychiatric diseases, people will be using those drugs over time. But they have to be done carefully. That, you know, some of these things are very powerful reagents. But I think it'll happen. It's coming. But I couldn't say. I'd love to be able to say to you, I think molecule X is the way forward. But we don't know that yet. But we know which box to look in, for sure. We now know which box to look in. So, and there are people doing it.
The lady in the middle there. Thank you. Yes.
I thought that was fascinating, thank you. My name's Hannah Clifton from the ME Trust. I think we're all aware that people with severe ME fall through the existing care net. I was severely affected myself. I had a call last week from a lady at home, bedbound, no help around, and she couldn't feed herself. That kind of thing's far too common. And I'm really interested in what you said about the effect of stress on this heightened activity in the brain. And clearly having ME is extremely stressful, we can all say that. But when we don't care for people's basic care needs, we're putting them in an acute place of stress. And I'm just interested in your thoughts about what that's doing to the brain and the harm that could be causing.
Well, as I said, I think of course, we don't know in the brains of humans. This is difficult, and we have to extrapolate from what we do in animal studies. And animal studies, of course, it's difficult to ask what would be an equivalent stress, what would be the right sort of stress. So people have begun to ask questions about stress that might begin to be comparable. So the mouse is put in a cage, and one day the cage is over here, and then it's put on its side, and then it's put somewhere where there's a lot of noise, and then it's put somewhere where there's a rat, because mice don't like the smells of rats and so on. And this low level of moderate stress, it's becoming increasingly clear that even that kind of low level of moderate stress can have effects on the innate immune system of the brain. So I think this will again be a growing area of interest, and how these interact with disease states. So I can't give you a clear-cut answer, except all I can say is, for sure, it would be extraordinary if it didn't have negative consequences. And this is true across the whole of mental health. I think that the fact that in the press just recently, some of our politicians have finally begun to recognize that mental health is actually important, is hugely encouraging. But I do think we have to push mental health up the agenda at all levels, and mental health for this group, for young people, for elderly people. It's hugely underfunded and underexplored. So we need to do more.
And presumably that could be really affecting people's physical symptoms. We're not just talking about an emotional and mental response, are we? We're talking about it causing their ME to be worse and having a physical result from that?
Well, as a biologist, of course, my view is, if things change in your brain, that's physical. And the fact that it makes you feel dreadful, feeling dreadful, is because it's going on in your brain and it's changing the circuitry of your brain. And these microglia interfere, alter the connections between one nerve cell and the next. So this seems to me it's about as physical as it gets. The fact that you feel it in an emotional sense rather than your hand goes limp, it's not an issue. They're all the same thing. So I think very important.
I've persuaded Sonia to talk fast in the next session, so I wonder if you just take a couple more. There was a lady to your right, in the purple top. With you, yes? You had your arm up earlier? Yeah.
I think in some senses mine was answered by a previous question. What I was going to ask was, are there particular drugs around already that can affect the microglia that you know of? Now, I'm particularly aware that, for instance, in MS, there have been studies of low-dose naltrexone in mice that have shown that microglia have been suppressed. Have any studies been done of any other drugs, or is there more work could be done on low-dose naltrexone, for instance?
So in the context of multiple sclerosis, which, as I said right at the beginning, is probably the archetypal, the best known of immune inflammatory diseases of the brain, when I first started working on it in the early 90s, there were essentially no treatments. There are now 10 different drugs that can be offered to people with multiple sclerosis. And many have emerged over the last 5 years or so. So, if you like, the science community, the clinical community as well, is beginning to understand how to use drugs to modify this autoimmune inflammatory disease of the central nervous system. And this hunt for disease-modifying drugs, as they're called, is on in the context, as I said earlier, of the neurodegenerative diseases, and I'm sure it will come into other diseases, and including CFS-ME. But they have to be done properly. They have to be set up as clinical trials, clinical studies, with the right groups in the right way. And as I say, I'm not a clinician, but it's clear that there's lots of ways of doing it badly, so it has to be done properly.
Absolutely. The very last question. There's a lady called Claire in the corner there who's tapping her watch at me. I'm getting in big trouble, but this is the last question. Lady at the back there, who've been trying for a while. And then I'm afraid we'll have to call the conversation to a close.
I'm the mother of somebody who's had ME for nearly 10 years, and he's now 26. And what he's said to me is, as he's gradually recovering, he's now beginning to get these colds and everything else like that. But what he has noticed is that the rate of recovery on the colds is slower than you would expect of a normal, healthy person. And I was just thinking, with your measurement of the microglia or whatever you're doing, would the rate of recovery of people who have ME, as they have these mild illnesses, as they recover, be a worthwhile area of research to add to your knowledge?
I think it's an extraordinarily, I think all of you will appreciate just how interesting, given what I've told you, how interesting it is, this relationship between infections that don't give rise to symptoms, infections that do give rise to symptoms, but now they last longer. There are clearly things we should be studying here, and I'm not precisely sure how we're going to do it, what we're going to do, but it certainly made me think that there are things to be done, and I hope it will make you think that you can push people to think about it more.
Yeah, thank you.
Hugh, thank you very, very much. You can probably sense the approval in the room, which is why you're still standing up. But it was really excellent, very comprehensible. As ever, the questions are at least, if not more interesting than the presentation itself. So if I could ask everyone to give Hugh a real round of applause.